pleased to welcome you to today's webinar, which is on continued dialogue around population-based behavioral health. Today, I am joined by three panelists, and I guess I should start by introducing myself. I have the privilege of working for all of you as part of the American Hospital Association in our Population and Community Health Division. And I'm joined today by three experts in population behavioral health: John Adler, who is the Chief Medical Officer for Credible Mind, as well as a practicing physician; Derek Van Brunt, who is the founder and CEO of Credible Mind and on faculty teaching concepts of public health and population behavioral health to students in Northern California; and then Debbie Zerner, who, like you, is a practitioner and is the Director of Community Engagement for Owensboro Health in Kentucky. So thank you all for joining us. Today, our conversation is going to focus more on the what and how of population behavioral health. And we've talked about the basic concepts. We've talked about how to think about setting up programming that's more expansive to help support patients and communities with their behavioral health needs. Today, we're going to be talking about measurement and how we understand impact of those programs. This is meant to be a structured but somewhat informal dialogue. So I encourage all of you, as you're listening, to put your questions in the chat, and we will get to them either in real time as we're talking, or certainly at the end as we open up for discussion to the broad audience. And with that, I am going to turn the conversation over to Derek to start us off, to help remind us a little bit of the background and set the stage for today's conversation. So Derek, take it away.
Nancy, thank you. Hi, everyone. We're going to take 3 minutes, and for those of you that weren't able to make the first two sessions, try and just quickly catch you up on some of the key concepts around population behavioral health, and then we're going to jump into our topics today. And just in one sentence, when we use the term population behavioral health, what we're saying is that we need to add prevention and early intervention, along with a smoother navigation to the provision of behavioral health services that we provide today. So this is an and. It doesn't take anything away from what we're doing today. The idea is to augment that with some of the practices that we've all learned over the years' work with population health. Why do we care about population-based behavioral health? Well, simply put, what we're doing today is not working systemically. And these are just a few of the numbers. The delay to treatment from people that have initial symptoms of mood disorders like anxiety and depression to when they get treatment is close to 10 years. We have roughly 250,000 behavioral health therapists short, often clustered in shortages in rural areas. And our costs associated when people have physical and mental health comorbidities, outcomes and costs are significantly higher, 3 to 5 times. So we have very serious challenges, and the rates around these are not going down. And so the question is, what are we doing? We can't just keep doing the same thing. We're losing ground. There is a real wonderful opportunity, and it's that stat down at the bottom of this slide, which is, it turns out that of people with mental distress, 3 out of 4 just want to know what they can do to feel better. What we might call evidence-based self-care. That's probably not what someone says to themselves when they wake up in the morning. And it might be on behalf of themselves. It might be for a child. But the idea is a huge opportunity for us that are thinking systematically in our hospitals and health systems about how to improve the people that we're helping. Also, when we talk about population behavioral health, we've been making the distinction of these different audiences. There's the communities we serve, our service areas in response to our community health initiatives. There's our workforce that needs help. And then there's our patient care, whether it's inside or outside the walls. We're going to be touching on how technology can be deployed to improve population behavioral health in all three of these audiences. We spent a little time in previous sessions on just technology. What is it that technology does that really helps in all of this? Because we're not trying to replace the interactions that people have with each other. It's rather about creating efficiencies. And you have two sets here. There's sort of traditional technology is the top row, and there's AI foundational new technologies listed below. And these are all responsible ways to use technology to improve mental health and well-being. Lowering access barriers by creating broad access where people on their phones can access resources. Identifying risk early, like with assessments. Personalizing self-care and navigation by seeing the history of what people look at and giving them more information and new information in areas that matter to them. And capturing real world data so that it's not just a study that was done in an academic setting, but it's been something that's deployed in communities around the country. And what are we learning? AI is helping us take it a step further and actually help individuals with guided, sort of self-guided therapy, or looking at multiple data sets and identifying insights that can inform an individual or a clinician with care that they might need, and supporting treatment decisions, like just taking the results of individuals using assessments and providing some of that risk data to a clinical team that's helping that individual. So these are all ways that we've talked about technology can help. There are many others as well, just to sort of get you acclimated to why are we having this conversation? Because these technologies can be deployed relatively inexpensively and can be a force multiplier in the impact that you have. Another topic that we've touched on is that when we do talk about technology, we're not talking about launching a website and then just hoping people come. This is about how you integrate information into the workflow in a community. We're going to hear more about this from our experts, but these are two or three examples. In South Carolina, when somebody calls a 988 line, yes, they get the initial response around crisis management, but then there's a follow-up with evidence-based information to help that individual or family members cope with the situation on a more sustainable, ongoing basis. Or the use of QR codes so that when people are picking up death certificates or getting their high school student ID card, that there are QR codes that touch them where they are in their lives, helping them with information like grief, cutting, bullying, etc. And so it's how you integrate this into, it's how you work with stakeholders in communities, how you work with your own partners within the walls of your institutions that really makes this useful. You need to take information and put it at the point where people need it. Again, we'll be talking about that in a little bit. So today, let's shift now to our focus. And our focus is success indicators. What are we measuring? Not just today, what are we measuring, which is lots of positive impacts, but what are the kinds of things that we can measure, more importantly, that you could measure if you start thinking about leveraging these kinds of things. So I'm going to share a few numbers with you. First, let me just put a little bit more detail into this concept of population behavioral health. What we're talking about is the use of technology to create a digitally integrated sort of front door that's accessible via like your laptop, of course, or on your phone, and allows an individual, a patient, a member, anyone in the community, to come in, take validated screens, GAD, PHQ, various assessments to find out what their risk level is. Again, maybe on behalf of themselves, maybe for a loved one. Find evidence-based resources to make positive change in their own lives. And then for those that want and need more care, to help find appropriate clinical care, we sort of think of a stepped care model where you don't just jump to medication. It might be that what's of use to you is peer support or coaching or online therapy, bricks and mortar therapy, medication management. So based on these constellation of information, keeping in mind that 3 out of 4 people are really interested in self-care, about 1 out of 4 are more interested in finding clinical care and helping everyone get to the right place as quickly as possible. So what do we measure as we're doing these? So I have 3 sets of sort of KPIs, system level KPIs. Think of it as a hospital health system. What is driving their quality metrics, their mission, their return on investment. So I'm going to talk about that for a second. And then we're going to talk about the individual, the patient. What are the KPIs for the individual and family, and then more nationally? So for the system level, there are 3 basic things that we're starting to measure with our hospital and health system partners. One is, it's not just about clicks. It's not that you just have a lot of people that are clicking around looking at mental health and well-being information. We've kind of introduced this concept of meaningful use, that people are doing something that we would all agree is probably pretty valuable. Like they've took an assessment to find out what the risk level is around sleeping issues or anxiety, PTSD, et cetera. There are dozens of these things. Or they found a resource local to them that often is very difficult for people to do and engaged with that resource. A huge KPI that we're now measuring. This is very exciting. One of the most exciting things I have to share with you today is that we have found, one, assessments are very popular. People love finding out how they're doing or how a loved one is doing. Is the risk high or low? Do I need to follow up on this? It's just of tremendous interest to people. But look at this. I mentioned earlier, we're 250,000 behavioral health therapists short, which means we really want people that need help to see those therapists. And if we can, have people that really don't need that level of care go into self-care. That would kind of clean up, it would lower costs. It creates a variety of efficiencies. And so what we're finding is that's exactly what's happening. Individuals come in, they take assessments. Of those that score low, medium risk, there's a 77% increased chance that they self-select into self-care. And for those that are scoring moderate to high risk, there's a 71% increase in the likelihood that they're going to click into and look for a clinical resource. So this platform, this technology is actually serving as a giant triage tool. Think of your audiences again, for everyone in the community as they're looking for services, as well as your own patients that are looking for services and your own workforce. So that is a huge KPI that you can measure and calculate economic impact from. And then finally, we get various third-party studies. So we had one third-party study. This is for a community-based implementation. And just giving you the punchline, they tripled access to mental behavioral health services in the community. And during that process, their costs went down. Not dramatically, but they went down a little bit, which is fantastic. I mean, that's what they were trying to do, is improve access, and they didn't want to increase costs. So these are the kinds of system level KPIs. If we look at patients, what are they saying when they use this kind of behavioral health, population-based behavioral health system? Well, over 90% are consistently saying it's helpful. They would refer it to a friend. Around 70% better understand their mental health. But I want to draw your attention over to the right. Consistently, over half of the users responding to surveys, this is survey-based, self-selected, response, say that they're making a positive behavior change. They're sleeping better. They're less angry. They're communicating better at work, whatever it is, the issue that they were choosing to work on. So that's really exciting. And then finally, the last set of KPIs we're looking at is, let's step way back and look nationally. This platform is now getting deployed around the country, and there are tremendous learnings associated with that. All the green colored states have at least one implementation, at least one hospital using this for their workforce, or one community that's using this to help all their residents, that kind of thing. And in many cases, a state might have 5 or 10 different instantiations going on as different people are doing different things. So what's happening is, one, the system itself gets better because we learn what people are looking at, and we're only looking at aggregated de-identified data, but we can see what the patterns are of various risk levels, the topics that people are interested in, the resources they're looking for, and building the best practices to try and find out, how do you integrate this into the workflow and actually make positive impact. So really exciting to see these sorts of levels. So I'm going to sort of wind up setting the stage here, and then we're going to hear from the experts doing these things in the field to say, well, what might you measure as you're sitting here today and you're listening to this and you're saying, okay, yes, we're in a national behavioral health crisis. Some people would say certainly there's elevated rates, and they're not going away. What is it that your organization might want to measure? And it really depends on which audience you're focused on and what your priorities are. So these are just some examples for you to consider as you're thinking about community health, you've done a needs assessment, you've got your prioritization and your implementation strategy. What are the kinds of things you might measure? Well, conceptually, you might want to improve access to mental health information and services, reach at-risk groups. It might be youth, it might be people speaking a certain language, a variety of different things. And then you can quantify that. And this example number down here is not sort of just a made up figure. You might target 10% of your entire geographic population as the number of people that you want to reach with this evidence-based information, say over a 2-year period. That gives you a little bit of time to kind of get the word out. If that seems bold to you, so I've got a population I serve of 200,000 people, and I'm going to set a 20,000 people goal to reach over the next 2 years, you could do that. That's how successful this kind of system can be. So that's one lens you might look at. Another lens might be your workforce. You know, we have, unfortunately, high levels of turnover with clinicians, physicians, nurses, and others, very expensive because there's shortages in these areas. So you might want to deploy this technology facing inwards and then set some metrics like reducing voluntary turnover by clinical staff by, say, 5%. Direct ROI and continuity of care improvement. And then there's your patient care. And here there are so many different kinds of metrics. But, you know, when people address mental health issues, and that might be a comorbidity with a physical health issue, you can actually make impact around reducing readmissions to the ED, for example. Imagine somebody who's been recently discharged for a certain condition. Maybe they're predisposed to a little more depression associated with the recovery of that. If that sets in, they're much less likely to adhere to their medication regimen. And so what you want to do is intervene early. So early risk identification, wrap that individual with some services that can be done at scale, and then actually measure things like reductions in readmissions. So these are the kinds of things that you folks might want to, think about. Obviously, there are many other examples. This is just to give you idea here. So let me turn this over to Nancy, and let's hear from the folks doing this in the field.
Yeah, thanks so much, Derek, for setting the stage. And I do want to bring in our field experts. So, Debbie, I'd like to start with you. So, Debbie, you've been working within your organization and within your community now for a couple of years to focus on improving mental health outcomes for your community members and support of mental health needs of your community. Can you tell us a little bit about what you've learned in that time?
Sure. I do want to say, Nancy, community engagement at Owensboro Health, and we are in Western Kentucky for our audience, if you're not familiar. Community engagement at Owensboro Health oversees our community health needs assessment, our implementation strategy. We have an investment program that we work with our community partners in an 18 county service area. Much of those counties are rural counties, and we align with population health. So community engagement at Owensboro Health falls under population health, and you marry that up with the fact that year after year, I should say every 3 years, that community health needs assessment is conducted, and mental health rises to the top each time since nonprofit hospitals after the Affordable Care Act are starting across the board to do assessments. It's risen to the top, and so you can kick that can down the road only so far. And so working with local partners, and certainly working with Derek and John, and the use of Credible Mind, we've learned a great deal. And community members are looking for some solutions to this, and they're not always looking for an inpatient appointment or inpatient admission or an outpatient appointment. They really do want self-care, and we heard that loud and clear. We engaged with Credible Mind during COVID. We knew the urgency to get something to our communities was front and center, and that afforded us the opportunity to do so. what we're learning is that it is creating an access point and a very solid open door to that self-care. The key is getting it to in the hands of those who need it, and that is no easy feat. As we have looked at the data year after year, knowing that certain age groups are using it in higher numbers than others, and our question then becomes looking at other data sets to say, okay, who is not using it but yet experiencing some really increases in mental health, anxiety, depression, burnout, to Derek's point. And so, how do we get this in their hands? And so, those are things we're continuing to, I think we'll always be learning new ways to do that. But I think that is just kind of an open area of opportunity for our hospital listeners in terms of access and engagement. Give them the access, engage with our communities, and begin to understand what their needs really are. And then you can adapt.
Great. Thanks for that. And I did see there's a question in the chat to be clear about what are KPIs, and I apologize for that. Key performance indicators, or basically, what are your key outcome metrics that you're tracking towards? So with that, I want to, follow up with you, Debbie.
Mm-hmm.
So you identified a community need. You're focused on access and engagement for folks in your community to be able to access behavioral health information that's been vetted. How is it that you are defining success, and what are some of the ways that you're measuring that to know that you're moving in the right direction?
Certainly usage. Derek, you pointed out three areas of community, our own health force, and inpatient and outpatient. We are really looking at those numbers of use. Uh, when you first start describing this platform and this intervention to individuals, there is some hesitancy as if people would really spend time taking assessments. They'd really spend any time at all because people tend to scroll very quickly on social media, on other resources available. Um, what we have found, however, and we share this at every opportunity, is the number of users since our use is 29,000 users, 34,000 sessions. And you can dive a little deeper into that, into the assessments. The assessments, some are very quick and some take a little more time. Our average user spends about a little over 5 minutes, which is really interesting. But the number of assessments that have been taken now exceed over 13,800. That's a lot of assessments. And I guess the last point I'll share with regard to those metrics of usage and how they're using and how much time individuals are using is that we're averaging about 1,000 visits per month. This follows so beautifully after Derek's slides. People are looking for a door of access to help themselves. And when you're talking 1,000 visits per month and the number of assessments that have been taken, people are utilizing this. Another metric to use is, are they satisfied with this? Are they returning? And we could go on, but Derek had pointed out what they're seeing across the nation. Our satisfaction rate is more like 98%. People are satisfied with this tool. So our quest is to continue to get it out there. And so those are some of the metrics that we are using in terms of success. Again, this is about access and engagement. And so we have to know if this intervention is actually reaching people and they're using it, and they are.
And I know that, none of us have a magic 8 ball at our disposal, but as you think about the next steps in the pathway for your organization in terms of population behavioral health, how are you thinking about using this tool or similar tools to capture data and develop new ways of understanding your population's needs and whether you're effectively meeting them.
Looking at each age group who's using this intervention and diving down further into the assessments they're taking, the issues that they are looking to address, allows us to create partnerships and programs, making investments in those, partnering with those. Sometimes it's not financial, sometimes it is more of really engaging our community members and our own team members in addressing some of these needs. And I, just share some examples of here recently with the pause on SNAP benefits. We have really been reaching out to local pantries, those who are key in our communities, looking at the populations they serve. And now we know we've got to get this into their hands. And so developing a process by which at every pantry and every shelter, we make sure that there's an access point to this intervention. That's kind of how we are using this. We're looking at what their needs are. We've seen improvement in some areas, and other areas, depression, anxiety, are still at the very, very top of all of the assessments that are taken. So in our implementation strategy for the hospital, we have created a strategy focused on sleep. And so Credible Mind offers a great deal of resources related to that. And we have other partners looking at that aspect as well. So we're going to take what are the assessments, the assessment data, the individual age groups, and look further at what their needs are, and then try to develop and partner around that in our community to address those needs. If no one's talking about anxiety and it's only talked about in circles, but yet everybody is taking an assessment of all of those users that is addressing anxiety, it's time to elevate that. And so how do we do that? That's kind of the way we will be using this moving forward. And it would be remiss of me if I didn't say that we are in trying times right now, all hospitals, all healthcare. We are certainly looking ahead at the next several years when there's going to have to be some tough decisions made. There's going to have to be some changes in delivery methods. There's going to have to be some changes, to many hospitals and outpatient settings in staffing and those types of things. These are some tough calls, and it's a tough season that healthcare is in. This is a tool and an intervention that can be shared among partners, both financially, certainly, but also innovatively, how we can continue to use this to get mental health resources in the hands of those who need it. At a certainly more cost-effective way, but a way that is evidence-based. And we know this is evidence-based. And so I think what we're going to see over the next 3 years is a real focus on the metrics, using those to develop more programming, partnering, really trying. I don't want to use the word in a cliche manner, but trying to be innovative and creative based on what we're seeing from this population level intervention.
So I want to call out one of the questions in the chat, because it's for you, Debbie, because it'll help expand just a little bit on some of the things we've been talking about. And you actually already answered part of it. So it's a two-part question, which is, what populations are you finding that are using your platform the most? And then, the second part you've started to answer, I didn't know if you wanted to expand any more, which is, which populations are you finding it harder to reach?
Sure. So our 13 to 17 and 18 to 24-year-olds are using this at rates that shocked us all, which is wonderful. At the same time, it seems like there's been a lot of rhetoric, if not actual legislation, that wants to limit the youth access to pertinent and real information that they need and they're seeking. And so I think that those two age groups is evidence that they are reaching out for help on a number of topics. And so that's been really beneficial for us to know, because we put strategies in place to ensure that those age groups continue to have access. On the opposite end of the continuum, at a time when we know we're going to see our aging adult population increase now for the next many years, we see them utilizing it less. And so then it begs the question, is why? Is it technology? Is it not an understanding? Is it they don't know that it exists? And I tend to fall on the latter rather than the first two, with a number of senior centers and the number of opportunities that our seniors have had to work with your hospitals, my chart and those. I think I think we don't give an aging adult enough credit. I think they have the ability to use technology. I think they don't know about it. And I guess I would follow that up to say you can do a lot. And Derek demonstrated some of the signage and the QR codes. A lot of this is face-to-face in terms of building relationships and trust and helping explain what this intervention is, and using those events and things that happen in your community to really expand upon that. The other populations, when you start seeing, such as our pregnant and postpartum women, when you start seeing your data in the community, not related to a Credible Mind, when you start seeing your own data that our postpartum moms are struggling, how do we get this information to them? Most recently, in fact, within the last week, we met with all of those providers, and they give a new patient packet out, right? Putting this in here and having that provider, this reminds me of the old days when a provider, we used to really key in on this. When a provider mentions something, that patient tends to pay a little more attention. And so now the providers understand that this is a resource that they can share with their patients, and it goes into a packet. So we've got to get that out to, and we're talking micro population. So we've talked about our youth, our seniors, and now you're looking at very specific populations. So whether it is in a food pantry, in a commodity box, or whether it is in a new patient packet, or whether it is on your own employee wellness site, continuing to let people know this is available. It is a door that is open to them. And then I've already shared with you some of the results of that.
Great. Thank you so much.
Mm-hmm.
I want to now bring John into the conversation. And John, you are bringing that clinician lens through your work. I'm wondering if you could talk for a few minutes about how you're seeing unmanaged or behavioral health issues showing up to our hospitals and health systems as an ED physician, and how you're seeing this impact the care that we're able to provide to those people.
Thanks for the question, and I want to say it's a real pleasure to be here and speak with people, and certainly welcome any questions. So as Nancy says, I work in the emergency department, and it's a pretty unique environment. So generally, we see people when they have gotten to really severe stage, and when people with mental health concerns are presenting. Primarily, I'd say the majority are when a loved one or a family member feels that somebody is really no longer able to, compensate or be functional, or have something really severe, or they may have voiced suicidal ideation or something like that. And so that's probably the most common presentation. And of course, we see kind of dramatic presentations. So, a patient I had recently was in a absolute, complete, psychotic, delusional break in the rehab facility where they were being treated for opiate withdrawal. So that, there's a range. Part of the challenge in terms of the resources is, for many of these patients, they, require initial stabilization, which is a real takes a lot of resources. And sometimes people come in with, 2 or 3 ambulance crews and police and require security and, et cetera. But after the situation is initially stabilized, they languish, often for days, and sometimes with people that are elderly or who have been violent, weeks in the emergency department waiting placement. So the drain on resources is very severe. And the care that they're receiving, rather frankly, is non-optimal because they're not in an environment that is completely focused on behavioral health. It's a busy emergency department. So um, we also I see personally patients who are there for one reason, but also are having a behavioral or emotional health concern, and that's not their primary reason to be there. But just picking up on something that Debbie was saying, as a caregiver, routinely when I'm discharging patients, I actually had to make a sound bite that I could copy and paste to, direct people to resources for anxiety or grief, or any number of other resources that we have on the platform to help them address this other kind of secondary concern.
So in a paper that you co-authored on population behavioral health, you suggested that there's 4 pillars to address that issue at the system level and upstream. And what do KPIs look like, or key performance indicators look like, in that model?
Sure. So, for me personally, this really led to, part of my journey to wanting to move care and assessment upstream. As a physician, we've seen the, huge benefits in areas like, heart disease and other places where population health has really paid off. And that's just not the case in the mental health and behavioral health world, where we're still in a reactive kind of situation. So I'm not going to focus, and thank you for pulling up this other information on the slide. The pillars that we talked about were just what Derek had referenced previously, getting something that can be really broadly accessed. Um, and so that digital access provides a level playing field. And in the modern world, even in rural areas and in underserved areas, there's very good access to, smartphones and other things. So for the access component, the percent of your population that you care about, whether you have a population health hat or a healthcare systems hat, if it's a community you serve or your own employees, what are you trying to achieve? And some real world examples are, generally we looked at about 10,000 client interactions and experiences. And we found the range is about 4 to 12% of the target population are interacting with the platform. But there are some kind of super success stories, and I'd say that Owensboro is one of them when, they're reaching kind of 25% of the population of their metropolitan area, that have done, even higher. Um, in terms of the screening component, you can look at these. I've highlighted both the percent completing screenings, but also the screening distributions. And that was one of the things Debbie was referencing. So if you see in your population that a lot of people are looking at, ADHD screening or post-traumatic stress screening, or if there has been a traumatic episode within your community, you can imagine and even proactively start to communicate out through the platform, material that's appropriate for that. One example we had was Monterey County, and this was the example Derek cited. So their behavioral health service helped about 13,000 people a year on average. And in the first 9 months of using the platform, they had about 30,000 people who accessed the platform. And the usual ratio. They had about 7,000 of those people who had taken assessments. One of the things we learned was about 86% of those who had accessed the platform or had engaged with it significantly had no prior contact with behavioral health. So this is helping to reach the, hard to reach populations or one that have particular risks. And then, you can kind of look through the table. The connection to care, I think, is also really valuable because that's the question of resources and working in a resource challenged environment, as basically all hospitals are. You want people to be getting the right level of care. And so the fact that about 77% of people who score at low risk are accessing their own self-care, and about 71% of people are 71% more likely is the correct term to access higher levels of care when they're scoring at moderate to high risk. And I'm just going to highlight that for 1 second. And that is moderate to high risk. So now if people are screened for anxiety or depression, both of which are coming online through primary care offices, if they score at high risk, there's a good probability that they will be referred into some kind of care, reactive care, or some intervention will likely take place. But if they score at moderate or low risk, it's like, see ya. And so that's like finding people that have pre-diabetes and leaving them alone until they're really on the ropes and have, organ failure or need insulin. So the fact that those people are being referred into appropriate levels of care or some kind of care is extremely helpful. And we had an example, say, in the iron workers union, who are clients. It's a mostly male-dominated group, so that's a little different than what we find for our user distribution. But in the first 5 months or so of use, they had about 30, well, we think 38 people who accessed very high levels of care, in part through the platform. And so those are people at extremely high risk. I mean, this may have been, a life-saving intervention for some of these people. So the connection to care and the connection to the appropriate level of care are things that can be measured, and we do.
That's helpful. And a question in the chat that maybe I'll throw to you, John, but Derek, if you want to jump into around that. In looking at this chart and hearing your description, these areas for identifying and data and using data seem to be pretty agnostic in terms of your population, whether it be an employee population, a patient population, a community population. But there's a question in the chat. Are there specific metrics for team members or employees that maybe aren't reflected in what you've described here that you would want to call out?
I'll make a comment, John. You jump in as you would like. A couple of things. So one, when you're looking at a workforce, often, and I saw another question related to this in the chat, one of the places they go for information is their employee assistance program, their EAP program. So there was a question of, do EAP programs utilize this platform? The answer is yes. There are many that have this embedded within the platform. The problem is most people don't go to the EAP, so you're sort of burying the lead. And so if anything, what people do is put the platform in front of the EAP and then go from this platform to the EAP for certain questions. So just to cover that. And I think, Nancy, one of the things that people want to look at is work satisfaction. You want to look at absenteeism. So there are some things that are more specific to a workforce that you can call out, both in terms of what kinds of topics, how people score in certain assessments. You could even look potentially at how people score in certain assessments by department. So the answer is yes, there is some additional information you might glean for a workforce.
Great. Well, why don't we jump into the discussion part? I actually want to go back to, there was a starter question. So this question came in while you were speaking, Derek, and I'm going to put my glasses on so I can just read it directly and not try to interpret it. But It was in reaction to the funneling that you described. And the question is, how do we tap into the middle of the funnel with innovative services and more intentional delivery systems? So I guess, kind of interpret it to you, how are you seeing hospitals and health systems think differently, use data to really redesign the population behavioral health delivery system?
Well, I love the question. It's a tricky question.
Mhm.
When you talk about a funnel, there are so many points of entry. We could just have a conversation for the next couple of hours about that. But let me just jump to two places. So there's the beginning of the funnel. I understand the questions are in the middle. I'll get right to that. But the first is, how do you just make, to Debbie's point earlier, how do you make people aware of things? How do you integrate it into workflow so that it's right where they are and they're becoming aware of a trusted platform where they can get evidence-based information, et cetera, et cetera. And there are absolutely best practices on how to do that, and the results are there to show for it. Let's jump a little further down in the funnel. We can also catch people during the course of their care. So someone has recently been discharged with a certain condition. Well, that probably ought to come with a packet of psychosocial information that's going to help them, depending on their profile. It's not just a little handout. It's, you're a parent and your child just got discharged for X. Let's give this to the child. Let's give this to you, and let's help the family function through this period. It's considerably more sophisticated than just here's a handout. So the good news is, technology is so sophisticated now that you really can look at different data points like discharge data, claims data, EMR data, personally identifiable data that's been collected during or personally shared information that's been, collected during like an assessment process. And you can look across different data sets now and pull together flags and then be proactive in information. So I love the question, because the answer is, how is your organization organized in terms of workflow? What are your goals? Where are the pain points? And let's work back to how we reach those people that are creating those pain points at the right time. And that's the future.
And so kind of following up on that, anything that you'd add about the type or kinds of metrics that we ought to be thinking about and
Mhm.
how technology that maybe exists today or maybe doesn't quite yet exist can play in capturing that outcome information?
Yeah, I mean, I think there's a whole evolution on the metrics. So first you'd start with your audience, right? Are we talking about for the community? Are we talking about workforce, patient, because the metrics shift around. If you're talking about community, I think the initial set of metrics was kind of more around um, engagement and awareness. I think that has shifted now, and we're measuring what we call meaningful use. Are we getting a large number of people in the community doing things that are meaningful and that science would say is having positive impact and that. But I think what we're going to be measuring more at a community level, I'm just on that sort of stack, is the use of resources that, it's like a gap analysis. We've got this population, they're coming in, here are the assessments. To John's point, we're sending them to those with higher risk to the right level of care. Let's measure that. There's an economic benefit to that. There's a quality benefit to that. There's a mission-driven benefit to that. Let's help those with lower risk into self-care and to help themselves. Let's measure this and let's celebrate it, because it's like an invisible benefit. It's not getting measured and it has tremendous impact.
And data is only as good as what we do use it for, right? So one of the things that we do all the time in healthcare is intervene or assess the need, intervene, act, and then look at the outcomes to see if we've had the intended effect. So, in terms of the work that you're doing, and I guess I'll point this question first to John and Debbie, although Derek, you as well, from an overall perspective, how are you seeing data drive refinements in the approach that organizations are taking to population behavioral health? So I guess John or Derek, do you want to jump in first?
I mean, there's so many examples here. There's a group, a community where they found that they had lots, they were surprised. Debbie mentioned this earlier. A large portion of people using this kind of platform on a community kind of use case are youth. And often transition age youth are a difficult group to reach, right? They're starting to smoke, drugs, bullying, cutting, all kinds of things. And they're difficult. It's a hard group to reach, especially then you add into that different languages and cultures. So it's great news that they actually like these kind of anonymous platforms. The key is give them evidence-based kinds of information, right? If we're actually, getting them in. So one group found that they had a lot of youth coming in, and they realized it wasn't really organized for younger people. So we worked with them and created a youth-oriented landing page so that when they got there, it felt right to them, useful, current, more TikTokish, and then dropped a QR code so that that could actually get out into the community, and boom, that the impact. So there's a data element. I've got a group that's interested. I haven't really organized content around them, and in doing that, getting that much more benefit. There's a group in South Carolina, and this is the 988, crisis line. Any
Mhm.
state could do this. And they noticed that, they felt a pretty good job on the immediate crisis management, but internally they did their own surveys and found we have nothing to follow up with these folks. We're not, there's no there afterwards, and we know they need help, and sometimes they're calling back. So they wanted tools to respond with evidence-based packages that could go to a family around, different kinds of topics. So I'd say that was another data-driven point, like a gap analysis point. Anyway, I could keep going. It's, there's a great need. And as long as your eyes are open and you're looking at the data, you'll find all kinds of insights.
Hey, John, what would you add from your experience?
Only that this is also kind of a two-way street. And so, we have had some collaborations where we have had someone start to use the platform, often in some like innovative way that we hadn't entirely thought of or anticipated. And then we look to try to understand what impact that has had. And so one example is a community here in Massachusetts where I am that has kind of three large towns in their catchment area. And they created a new program where they had clinicians who would respond to this kind of a crisis situation out in the field. And then working with them, we were able to evaluate their data and determine that over, we wrote an abstract on it. I forget the exact time period, but there were about, I think in over 2 years, about 800 people that were diverted from having to go to the emergency department that otherwise might have, and a smaller number that were diverted from going straight to jail and being arrested. And in part, they would have this material available to them in the field. And now there's another group that has adopted this as a component of their in the field outreach program.
Thanks for that. Debbie, I want to give you a slightly different question as we're coming up towards the end of our hour together, and there's still so much that we could talk about. What I've heard from you, John, from you, Derek, from you, is that this approach, as many of our approaches in healthcare at the population health level, is built on partnerships, whether that's partnerships within your organization to coordinate activities and resources for patients, or partnerships in your community to, again, get the word out, get people involved, respond to people's needs. And I'm interested, and I know there's no magic answer to this and no set answer to this, but how are you thinking about, for your organization, measuring not just the success of the programming that you do in partnership, but understanding how the partnership itself brings value to your organization, to the organizations that you're working with?
There is no magic answer to that, but I will tell you what has transpired, because we had just ourselves and our community mental health center that engaged with Credible Mind and have both funded that and then working together to do all the things we've already discussed. What came out of that, and I've shared this in previous sessions as well, along with the American Hospital Association, the community learning sessions, if you will, is we built a mental health collaborative. And that was a hospital, it's one of our strategic imperatives of partnering with our communities. And we actually set that as a goal with an objective and have been measuring what we've been doing for the last couple of years. It happens to be that we formed two collaboratives, one related to housing and one related to mental health. That did not exist before. And so looking at the success of that mental health collaborative, now bringing on additional partners, the local health department, for example, and including new individuals in that collaborative, we're beginning to take this in different ways. So integration of services, for example, between partners that didn't exist before. And so that is a marker of success that is not necessarily related to Credible Mind, the platform. It has resulted because of our partnership that we built to bring this to our community that has taken it to a next level, if you will.
Thank you for that.
Mm-hmm.
Now that we're coming up on just the last minute or two of our time, so I want to just do a couple of quick wrap-up slides. But as we're bringing the slide deck back up, Derek, there was a quick question in the chat that I think just is a very quick answer in terms of how can folks who are on the line or listening in at a later date find out whether this platform is in their community or who they might contact in their community who might be using it already. And so is that something that they can get from your website? How can folks find that out?
You can see right here contact information, let's say on the left. If you send a note to Scott Dahl and just let him know what state you're in, we don't list it publicly across the whole nation. There's so many partnerships out there. But if you tell us your state, where you are, what kind of organization, we're happy to share anything that's publicly available in terms of implementations. And one other just 30-second comment on this whole partnerships. There are so many community partners interested in working with hospitals and health systems on this that we've actually created what we call a playbook, a sustainability toolkit. It lists all the stakeholders and what they're looking for so that you can speak their language. And we're happy to give you a copy of this and talk with you, because I just completely agree, Nancy and Debbie, it is about building those partnerships, setting up joint KPIs, and that's how you can really move programs forward at a community level.
Great. Thanks for that. I want to take a moment to thank all of our speakers today for sharing their time and expertise, to thank all of you in the audience. If you want to continue to engage with us or with Credible Mind to talk a little bit more about this, you can reach out to Credible Mind directly. Check out our website around our hospital community. We are having a live virtual workshop at the end of January focused on behavioral health partnerships in particular. And then we also have, and I encourage you to save the date and check out our website for our Healthier Together conference, which is really focused on the power of partnerships to make changes for communities and for patient populations. With that, I will wish you all well. And again, thank you for the work that you all are doing in your communities every day.